Fine.
Okay. We'd like to welcome you to this week, the Patient Safety Week of London School of Paediatrics. We have Davey with us as our first presenter this week. She started her career as a pharmacist and has then become the trustee of the Clinical Human Factors Group. She is working now with the London School of Paediatrics in their quality improvement program, and she is a QI practitioner who is making lots of the LSP trainees into change champions, and much of the work that they've done has been around pews and other safety initiatives. And so she's going to kickstart this week with an introduction into some of the theories behind patient safety. Thank you so much, Nicola, for volunteering your time and effort. And we really are so grateful.
That's great. Thanks very much, Merit, and welcome to everybody. It's really great to have you all on the call, even if I can't quite see you at the moment. So today I'm going to do an introduction really to patient safety, and I'm going to use some of my previous experience working on the deteriorating patient as an example as we go through this. As Merit said, I wear a few hats these days, and in particular my relationship with the London School of Paediatrics is through this wonderful programme that I run with Jane Runnacles and lots of other fantastic people on quality improvement, and we're producing lots of change champions. So if any of you are interested in the programme, please look out for it and think about whether you might want to begin your QI journey. Today, I'm going to cover the various things, and as I go through these, I'm also going to just try and flag up through a not so subtle bubble on each slide other people who are going to be speaking to you in more depth about some of the subjects that we're going to cover. So I hope that's a little helpful advert for them and a little place marker for you to think about whether you want to join those webinars too. So first of all, I want to start with this slide here. First, do no harm. It's the sort of premise of our practice. And you are all amazingly qualified to do the work that you do. At the same time, you are human like everybody else, and therefore you are destined to make mistakes. And those two bedfellows are quite uncomfortable to have in close proximity. And so what we need to do is look for all the help that we can get to find ways of addressing the natural deficits that we have. So those natural deficits mean that when we're working in a complex system that's perfectly designed for the outcomes that we see, that means that we're going to have the wonderful saves that you make on a daily basis, also some slips and trips and that you might catch, and also the ones that shoot through, so the complete drops. And that's the scary bit really, isn't it? All the stuff that we don't necessarily see that we've dropped or left behind. And what we're trying to do through our sciences is learn as much as we can to make the care for our patients safer. We don't do that just by working harder and trying a bit harder, you know, that's not enough. So we have to learn the other strategies that we can use. So I'm going to talk a bit about some of those strategies now. I'm going to start off with a look at four of the sciences that we can draw on. Evidence-based medicine, ergonomics, improvement science, and of course, patient safety science. So I'd like to hear from you actually, as our first go at using the chat. I would be interested to know which of these sciences was the first that you experienced, and then what was the order that the other ones were that have come to you, although some of them you may not have come across yet, really. So we're going to do that in the chat by using the initials, because that seemed the easiest way to do on this system. So I wonder if you can put in there, in order, the which of these sciences were your first one and what was the next? Maybe just start with the first one, that would be interesting. So which of these are you most familiar with? Evidence-based medicine, yeah. Oh, yeah. Okay. Brilliant. So everybody's saying evidence-based medicine, and I kind of think I'm relieved to hear that since we're in medicine. But somebody's human factors and ergonomics was their first port of call, so that's interesting too. There's no right or wrong, by the way, about which order you come to these sciences. It's just interesting to think about that and think about how we might develop as we go through our learning journey of life and learn more about each of these sciences and how deep we need to go into each of them in order to be able to usefully use them. So not everybody's answered that. I don't think. I saw a few. So anybody else want to put the chat? Feel free now before I move on. A few more coming in. Okay, so evidence-based medicine was my starting point as well back in the day. So I'm going to start with that here. So evidence-based medicine, my champion of this is Trish Greenall, shown here on the left. Now, Trish is an esteemed researcher and commentator on healthcare. She's been behind the current Wear Masks campaign. But she also draws on her own personal experience, and she has written some challenging articles about evidence-based medicine, two of which relate to her own healthcare. One around falls, when the falls guidance, when she fell off her bike, would have been perfect, but they looked at her and didn't think that she was old. And so they didn't apply it to her until she worked out what was wrong and made sure that it was applied. And she also had cancer treatment, which she had exemplary evidence-based medicine treatment. But she also plays with this a little bit by tweeting things like a conversation between a doctor and a patient, which I find quite amusing. So the doctor says to the patient, "Don't confuse your Google search with my 6 years at medical school." And the patient says, "Don't confuse the 1-hour lecture you had on my condition with my 20 years of living with it." So she's really good at kind of getting us to face up to reality. And so on the right-hand side here, we've got a paper around deteriorating pediatrics and early warning scores for deteriorating patients. And this is a systematic review, I think, published in 2017. So I began working on PEWS, I think, around 2010. And we were really clear that there was a lot of unknowns around it. And so in this report, they highlight that PEWS should be embraced as part of a larger, multifaceted safety framework, and that future research needs to investigate PEWS as a complex, multifaceted, socio-technical system embedded into the wider safety culture. So there's a lot of long words there, and those long words come from other sciences. So I will touch on those, but also we have a speaker that's going to present later on that will cover some of those in more detail. So the second science is patient safety science, and this is Sir Liam Donaldson, who was the Chief Medical Officer for the UK. And in 2000, he championed the introduction of the idea of human error and how that is causing harm in our health service. And in America, they produced these two publications you can see in the middle, and we had Organisation with a Memory, or OWAM as it's sometimes referred to. And in this publication, that was probably our first sort of introduction to the idea around the Swiss cheese model, which I'm guessing most of you may be familiar with. Would that be fair to say? So that was James Reason's model. And going back to deteriorating children once more, the evidence has been emerging sort of over time. So this takes you up to 2012. But over time, people were beginning to recognise and count and talk about the failure to measure, the failure to recognise deterioration, the failure to communicate, and the failure to respond. So a number of different places where failure could happen. So I hope you can see there that until about 2000, patient safety wasn't really systematically studied. It wasn't really counted. The amount of harm we caused wasn't really known. And I know we've gone 20 years since then, but we still have a lot of unknowns. So if you want to know a little bit more about the person who gave us the model, Swiss cheese model, and looking at latent errors. This is a really good read here, Life in Error, by James Reason, and it's a really readable, accessible book about his journey through to learning about human factors and becoming curious about stuff. And I've put here also that you're going to be doing a piece on root cause, so you can play into that session if you want to learn a little bit more about that. And then from there, in patient safety terms, we've moved on, and we now have the model called Safety 1 and Safety 2, which Eric Holnagel published in 2014. And Peter's going to be talking about that this Wednesday, Peter Lackman. Now, both of these guys, one's a psychologist, one's from engineering background, they both have come to healthcare through different routes, and that is not their first profession. So they bring a fresh lens to looking at these sorts of challenges. And then ergonomics and human factor science. So this is the first time that it was really brought to bear in healthcare. And what we have here is we have a report into the death of Wayne Jowett. Now, many of you may not have heard the name Wayne Jowett, but he was a young man in remission from leukemia, having his final doses of vincristine when it was injected intrathecally. So you've probably heard about that kind of error and the amounts of effort that are now gone to try and avoid that type of error. But the reason I've put this slide here and the reason it's so significant is because this was the first time that someone with a human factors and ergonomics background was really brought into a mainstream incident to look at what had gone wrong. And that was Brian Toft, shown here on the left. And it was Liam Donaldson, who brought these people in, who said, we need to look at this differently. We need to learn in a different way. So that was our first taste of it. In the same year, the following year, so Liam also oversaw the publication of Learning from Bristol. And this was the Bristol inquiry into the deaths of children who'd had cardiac surgery. Now, this was a very different type of incident, if you like. It involved many people, as did the vincristine injections, but these people were all in the same trust. And actually, this was a far more systemic problem, far more complex problem, which something like the model, the Swiss cheese model, doesn't really help us get in and understand quite what went wrong here. It's a very deeply ingrained culture issue. It's about not speaking up. It's about suppressing information, suppressing data. So, you know, hats off to Liam for getting this out after so many years sitting around, because the actual incidents happened many years before this, the publication, 84 to 95, so a long way back. So in terms of human factors, I can't fail to mention Martin Bromley here, who is the founder of the Clinical Human Factors Group. And as a trustee, I'm curious to know how many of you have actually seen this video. It was made quite a long time ago now, but it is used in routine training. So I wondered in the chat if you could think back to when you did first see this video, if you've seen it. And if you haven't, it would be really interesting to say not seen, because times move on, don't they? And we don't know what people are being drawn to and using in training all the time. So if you can type into the chat, if you can think back to when you saw it, that would be really interesting to know. Okay, so medical school. So some people not seen it, some seen it in simulation training, some seen it right back at medical school. Anyone else? Okay, well, you can Google it on YouTube. Very welcome to have a look at it. In it, Martin talks very frankly about the death of his wife, who went in to have a routine operation, and the types of things that went wrong, which in his industry, which is the airline industry, would be looked at and investigated in quite a different way than was proposed in 2007. Luckily, Martin's a very persuasive person, and he persuaded the organisation to undertake a full review, which is why we were able to make the film back in the day. Excuse me. So so as a charity, CHFG has campaigned and we've campaigned for 3 things. One is for patient safety design, which we're still campaigning for. The second was learning from success and failure in the way we do investigations. And the third was around education to promote human factors learning. And it was through the campaigning in a large part that we were able to get an independent investigation body created in 2017 called the Health and Safety Investigation Branch. And this organisation uses the types of industry standard approaches informed by human factors and ergonomics to undertake investigations. So the sorts of skills which are at the moment quite difficult to find and come across in healthcare are invested in this organisation. And so in 2018, they produced one of their first reports, actually, which was about undetected battery and coin cell battery ingestion in children. So this is a really interesting report. But I suppose I also wanted to highlight that back in 2015, when we made a series of films in what's called the React series, we have here Rachel Rowlands talking about that experience herself and about spotting the deteriorating child. So in your resource pack, I've done a link to a series of videos that were made, which are really quite good, talking about different facets of patient safety and human factors and learning. So worth a quick glance if you have the time to look at it. Oops, sorry, I've skimmed over that one. So I spoke earlier about the fact that in the Bristol incident, and probably in some of the other high-profile incidents involving children and maternity services that we're seeing at the moment, the Swiss cheese model isn't really it's not really able to accommodate all of the sorts of things that are going on there. And so what we have here is a model called the SEEPS model. Now this, for me, I find this a really comprehensive model. It's relatively simple in the way that it's presented, although underlying it, of course, there are layers upon layers of complexity. But you can see here that we have the work system described and the interplay between work, people, organisation, so that involves the culture as well, the tasks and our internal environment. So all of those interdependencies which can come into play when things go right and also when things go wrong. And it's through these interactions that we have the outpouring through processes into the outcome for the patient, for the staff, and also for the organisation. So in that interplay, as it comes out, we have an adaptive process that goes on, which of course varies quite a great deal. Sometimes the variation is great and sometimes the variation is really not so good at all. But one of the worrying things is we often don't really know what the variation is. So Simon Fleming is going to be talking, the time has changed now to Friday, on culture change, safety, the patient and the profession. And that really covers this part of translation between what happens between individuals and what happens when that plays out through the work processes in order to deliver the care that you deliver. So this is a great model to begin to think about. If we were looking at this in terms of deterioration, then we can think about the different steps that I mentioned earlier in deterioration. So it's not just one simple step. There's the measurement and recording of the observations. There's then being able to recognize that actually maybe they're not quite right. Maybe something's happening. Maybe a child is deteriorating. And then being able to call for help really effectively and get a timely response. So the solutions to these kinds of problems to ensure that every time a child is looked after well is multifaceted. And when they talk about socio-technical systems, they're talking about the interplay between people and the system around them. And it's really complicated. So designing such systems require us to acquire a deep understanding of the problem. And again, this is something which we don't always spend our time doing to the extent that we might. And that's certainly something in improvement science that we do a lot of work on, which is understanding the problem before we start trying to find out the solutions. We're hardwired to solutions, so we just tend to jump straight there. And we need to hold ourselves back and learn more before we go forward. So I sort of think that's very similar to when you look after a patient. You don't see a patient and immediately devise your care plan. You go through that stage of diagnosis, finding out what's really underlying there. And then when you've actually found out more about the problem, that's when we might be looking to use human factors principles to make it easier for busy clinicians to do the right thing. So that's what we try and do. So when I first started working on pews, which is quite some time ago now, we didn't just find it was complex, but we also found it was complicated. And I know this is an old style slide now, but I do wonder how much variation is still out there in your experiences in that whole process of, you know, what kind of machines you use to take OBS, you know, is it VitalPack or is it something else, or is it still using paper? Do you have the same thresholds for when you escalate? Is it straightforward to know how to escalate, who to escalate to? Does it vary? All of those questions are in our minds, and all of those are the sorts of things which get in the way of us progressing, get in the way of us being able to do things really easily when we've got a million zillion jobs on and we're trying to juggle all the balls. So it needs to be really simple for people to do the right thing. It doesn't matter how bright you are. If you're tired, adding up a line of figures isn't going to be a great job to do well and reliably. So in the work that I was involved in, which is in 2011 to 2012, this was our work that we did trying to standardize a PEWS form. Now, we weren't looking to do a national PEWS form. We were looking to come up with a template to guide people about what a good PEWS form might look like. And so this is just the design piece of getting a good form. There are so many different factors to look at, and there is a science behind a really good design. So the book on the right here, shown here, is a really great resource from Australia, where they did a whole load of research about the kinds of things which humans attend to and the things which make it easy for them to read a chart and harder to read a chart. Clutter, abbreviations, tiny font, so many different things that can get in the way and make it easy for us to slip up. You know, complicated scoring systems where you need to multiply numbers and they're different in different boxes. This is not perfect, but it was a result of looking at it. I think we had about 40 trusts involved looking at what they all did and tried to develop some consensus about what the important things were. I think there's some more work going on that now. So going back to those truisms that I said at the beginning about first do no harm, there's another truism, which is that we can't change the human condition. We can only change the conditions under which humans work. And so that's why in a systems way, we need to understand better what the system is that we work in and really think deeply about the kinds of changes that we're going to make and use every bit of science that we have at our disposal. So this brings me on to the fourth science, if you like, improvement science, which is now my sort of day job, and the model for improvement, which is one of the methods that we use to manage change. So many of you, if you are familiar with improvement of any sort, you're probably familiar with this cycle on the left, which is the plan, do, study, act cycle. And on the right, I've put here the audit cycle. And I have had some really interesting conversations with doctors over the years about them being the same or different. They are very definitely different, and they have some similarities. Small scale tests of change, PDSA, is not at all the same as doing an audit. But the the thing that can be really useful is that with audit, the big challenge is around implementing change. So that top quadrant on the left of audit is often the place where things fall down. That's the place where clinicians move on to their next rotation, leaving a set of recommendations. And so one of the things that you can think about is using the model for improvement, using the PDSA part here to drive change. And that's not about doing one PDSA cycle. That's about doing many PDSA cycles to work out what the change really should be that's going to work. And I'll say a bit more about that in just a moment. So I hope, I don't know if anybody's willing to put in the chat whether they've been taught that they're the same or different, but it would be really interesting to me. Anyone willing to say if that's news to them, that they're different or the same? It might just be the doctors I've spoken to that thought that they were the same. Anyone willing to give it a go? Okay. I've been taught they were different, but nobody's ever been able to explain the difference. Okay. So this is a very fast presentation. So I have put some ways that they're different here. Essentially, the audit cycle is a compliance cycle. It's to check whether or not something is being done and show you the gap or the deficit, and then to help you think about how you can overcome that gap. Whereas the PDSA cycle is a learning cycle. It's about testing something to see if it works and learning whether it works or whether it doesn't work, and then learning whether we should carry on with it or change it a bit more, or actually just dump it because you know what, it wasn't the great idea we thought it was. So quite a few things in there that make a difference. They come from a different philosophy, but they are both useful in healthcare. Oh, sorry, I think I might have jumped back a slide. Oh, okay. So this is a bit of a definite interaction section now, because what I've got here is a change model. It's called the model for improvement. And what I'd really like you to do is tell me what you think, what words you think might go in those boxes. So I've already told you that at the bottom box, it's PDSA, Plan, Do, Study, Act. But actually the model is a scientific model that's been put together with the Plan, Do, Study, Act cycle to make a change method. And so anybody wants to venture into the chat box and tell me what they think the word might be in the top box? Nobody wanting to do? What? Not sure. So what, reflect? Okay, so what is a good start. Identify, that's a good start. So the question we ask is, what am I trying to achieve? So you might also say identify what you want to achieve, but the shorthand word that we use in that box is aim. So what are we trying to achieve? And it's a really powerful question that often remains unanswered. So the second box, I'm going to just go through these because I'm suspecting that maybe many people don't know them. So the second box is actually about measure, and that answers the question, how do we know we've achieved our aim? So it's not about going straight to the interventions, it's not going straight to the solutions, it's actually saying, how would we know that we've got there? Again, something we're not really very good at in healthcare, and we don't tend to do it in a timely manner because we don't want to know next year whether we've got there in improvement. We want to know next week or next couple of weeks. We don't want to wait forever to find that out. And then the third box talks about change ideas. So this is about exploring all the ways we could improve. And we're not very creative about that. We tend to go back to the thing we had in mind when we first decided we were going to fix something, and then go, oh, there we are, we think that fits. Our great idea is bound to work, which it often does when you're there. But when you leave, it usually goes, but you don't see it. So these three questions are the the 3 questions which are added to this to make it a model for improvement, and we have PDSA at the bottom. So anyone want to, I do this with all my trainees, I hope you don't find it too intimidating, but you can think about whether or not, if you want to say whether or not you know the model for improvement, we're really talking about the whole of that thing in the pink box. And you can say whether it's the first time you've seen it, as in the whole thing in the pink box, seen it and tried it, or trying it, know it and use it, or use it well and want to learn more. And if you're honest with yourself, then that will give you a really good sense of where you are with this particular science. If you're trainees, you probably will be, you might think that you'll be in a lesser knowledge position than anyone else, but actually most of the trainees I teach up to ST8s at the moment, the number of people who come on our program who actually are familiar with this method is incredibly small or not there. So the people who know about it are our mentors and our faculty who've learned and trained about it. So great. So a few people are willing to say, if you want to put your score in there, please do. It's interesting, and it's good for you to recognize for yourself where you are with it, because you will come across people who tell you that PDSA is the improvement method. Or we've got some people here who really know it and use it, so that's great to see as well. So their initials, that's fine. Okay. So does anyone else want to answer? Okay. So it's a shame we haven't got a polling system on this, because that's always good fun, isn't it? So just to put this in context, just going back to the deteriorating patient as an example, just doing the chart, just getting a good chart design. This is work that was started by Sebastian Yun back in, I think, 2010. I worked with him, and we went through many iterations at the Royal Free to get a form that was more evidence-based. And then we worked with about another 40 trusts to come up with the template that I showed you earlier. So the improvement method helps us establish whether or not the changes we make to a form actually make a difference or not. And so if you do get new forms of any sort to do any task, then there's no harm in running a test to see whether or not people can use it more easily than the previous form. Whether you will all know that some of your IT systems you use work better than what you had before, and some work a lot worse. Is there a way of feeding that back? How do the ones that work poorly get out there? Did anyone know when they launched it that it was going to make your life really hard? Possibly not. Most people don't go about maliciously making programs that don't work for you. It's just the way the system is means that that can happen quite easily. So just going back to how important it is for looking at safety, there are 4 steps. If there are 4 steps to patient safety around deteriorating children, how hard can it be? I know that you're going to hear a lightning style presentation from Justina about escalation later on in the week. But if you look at the science and you look at what happens if you have 4 steps in a process, this is what it looks like. So if you have 4 steps in a process and you have a 99.99% reliability, that means more than 99 people out of 100 get a really good service. Then after 4 steps of each being at 99% plus, you're going to still have about 99 plus people out of 100 who have a good experience. However, if it's 99 out of 100, you get 96 out of 100. But more worryingly, if you have 90 out of 100, so 9 out of 10, which most of us would think is a really good result, when you go through 4 steps of it being 9 out of 10, on the 4th step, it's actually down to 6 out of 10. So 6 out of 10 children will reliably go through that process if you are performing each task at 9 out of 10. So it's scary, but if you apply that to some of the tasks that you're involved in on a regular basis, day in, day out, you can see that actually this is where the human piece comes in that we save some of these. Out of the 6 out of 10, we do a lot of saving. We do a lot of workarounds, which costs us and takes us time. And we do it again and again and again because we can't find a way to break out of it. So I'd like to pose a question for you about does variation prevail and how would you know? So at the hard end, you've got the team error, the thing that comes out as being a real critical incident. But at the moment, for example, we're moving from face-to-face to virtual consultations. And we're asking ourselves, do we know how that varies? Do we know how we vary in the advice we give to people, particularly if we're working in a clinic and nobody else is there with us? And does that translate into even more variation when we go virtually? What's the quality assurance? How do we know? So is the outcome the same for the patients? I'm doing some work with somebody at the moment who is looking at the differences between themselves and colleagues in terms of what they offer as a baseline to young people they're seeing. And they're finding that there are differences that nobody really knew about. So these are the sorts of questions you need to be asking yourself as if you want to get really inquisitive about patient safety. And of course, all these sciences that I've talked about are required to deliver patient safety. We're beginners really at some of them, and we're more advanced at others. And there's a long way to go, but we are making steps forward. I've listed here some of the things that are being covered today, in things like CRM, where you talk about safety huddles, you talk about whether you've got the same mental model, whether or not you're prepared for slips and trips, for things which might go wrong. And you will know if you work in different teams that in some places it's done really well, in other places it's done less well. So getting patient safety better involves getting our processes better, more reliable, and understanding what the variation is so that we can decide whether that's a good variation and really helpful and focused on the patient's needs, or whether it's just a variation because the system contains a whole load of things which make it difficult for us to do things in a really great way every time. So that's something to think about. And also the psychology of safety as well, which is a really big part of this. And I know that Daniel's going to be talking about that on Tuesday, so that might be something you want to listen into, particularly given the current environment that you've been in. So before we go, we've got some time for questions and also for an opportunity for you to say something about one thing that you might take from what I've covered today. We'd be interested in that. It's great to come on a course like this or a talk like this, but for each of the talks that you go on this week, I hope that there's something you'll take away with you. So would people like to put into the chat box one thing that you'll take away, one thing you've heard that you think, oh yeah, that could be useful for me? It's more than a pledge. If you write it down, it's a pledge. The difference is taking it through into an action. So I think that would be really great if you could at least make the pledge today about something you've heard and share that. And we can open up for questions as well. So you can either type your pledge in or you can put some questions or challenges to me about things I said if you don't agree with them. Merit, do you want to come in?
Yes, I was just gonna put my pledge in the chat box, but
What's your pledge? Share it with us.
So what you were talking about in terms of socio-technical systems and seeing how the two interact and spending time to understand how these systems play together and how then it manifests into opportunities where things go well and situations where they don't go well, and actually spending that time to think about how they interact with each other, I think is a very useful thing and probably something that we don't do enough in when we come to a new job and start working. So that's my pledge.
James has opened up his microphone. I don't know if he'd like to speak. Was that deliberate, James? Would you like to speak? Could be accidental. No. So
thank you. So if anyone has any questions, go ahead. Oh, I thought I heard someone speak, but no, maybe not. So if anyone has any questions, then please type them into the box or raise your hand. Nicola, I just had a question about the Pews chart. So like some of the other devolved nations have a national Pews chart already in place.
yeah.
And I just was wondering if you could give us some insights into what is the technical, or what are the difficulties and challenges in making a national Pews chart like standardized? Like, why has it not already become something? I know there's work towards it in the UK, in England, sorry, but why is it not like a given?
So I took part in a debate actually with Dana Rose and some other people a little while ago about this. It is a tricky one. I think there is one that will come. I think there's still a lot that we don't fully understand. So James put here, there's a national Pews chart coming from NHS England. So
Yes,
in principle, I think it's a really good idea to have it standardized. My own experience has been is that people, so there's quite a difference in what I've seen in practice between sort of tertiary centres and DGHs, for example. There's quite a different profile of the patients that are seen. And I've also seen people take these charts and adapt them. So if you adapt the charts, that can be really monstrous, because I've seen people do things with garish colours, with really poor reproduction and with a lot of clutter all over them. And people have to navigate through them, which is really quite scary. So I think the standardization is quite a good idea, with the proviso that I think the difference between the tertiary centres and the DGHs is, you know, I don't know, to my mind, from what I've seen that it would be quite, you could, so somebody's put here, James put a lot of debate about scoring and including BP. So when we did our templates, there was a lot of debate about what should be in and what should be out. And so we were really trying to understand that when we tried to do the thresholds about what would be normal thresholds to put in the banding. At that time, the evidence base for what were the right trigger points really weren't that well established. In fact, we found that there were 3 different published charts of what the threshold should be. So deciding which one to use was a challenge. I rang up Peter and I said, Peter, what do we do? Which one should we choose? How do we decide? And then also James put here the local escalation, which can't be standardized. So it kind of gives, my worry is it gives a slight false sense of security, because at the end of the day, unless you've got an electronic version, we know that the adding up of numbers or ticks or whatever system you use is actually quite unreliable. So if you do audits of seeing whether people scored well, it doesn't come out that great. We also find things like when people have got the score, they then stop kind of monitoring, because they get the score, they do the escalation, and they think they've handed it off to someone. So standardization doesn't get around that. You can have that with any Pews form. I think there's just a balance to be struck, and I do have a little bit of anxiety over it being one size fits all, if I'm honest. But I'm not a paediatrician, I don't work with it every day. So you know, once one's done nationally, people say, well, it's been done nationally, so we have to do it like this, so we're doing the gold standard. And again, that's slightly you know, it can allow people to sort of be a bit complacent, because I want to know how well they really are doing. You know, do they know how well they're doing with it? Do they know how well they're performing? Or are they just saying we use it so CQC's off our back, which is actually probably quite often a reason. So that's going back to your compliance. So yeah, a good question. And Jane's been putting here in the chat, they're piloting the national one at St George's this autumn, and they're using electronic version and the escalation, which can't be standardized. You know, one day we could dream of a time when escalation could be more standardized. I teach people SBAR. When I ask how many people have been taught SBAR, a lot of them say yes. When I ask how many people use SBAR routinely, so that's a structured communication tool, standing for situation, background, assessment, and recommendation. I find that the numbers of people still using it on a regular basis are really quite low. So it's great to design the right thing. That's one part of it. Changing behavior is a completely different part of it, and that involves both psychology and change methods, not just the kit or the bit of paper or the electronic system. So yeah. Any other questions?
I just had another one until other people think of questions. With regards to the 4 sciences, so I think lots of us had said that we're all quite familiar with evidence-based medicine, but not so much with the others. Do you think there's scope for education in medical schools? Do you think that, from your perspective, is that changing? Because this wasn't, I don't think these sorts of sciences were really that well taught, if at all, in medical schools. And so what's your thoughts about when would be a good time to introduce this sort of education to clinicians?
So I think starting early is always good. Again, the experience is people have often covered this in medical school, but then when they come through, or even in trainees, but then they come through the system, and actually the system hasn't caught up yet. So they're still struggling for the recognition. I mean, to be fair, evidence-based medicine took years, decades to actually really become the norm, if you like. And now, as Trish Greenall has mentioned a few times, there's a bit of a challenge because it's almost being, there are areas where it's being misused now. So she's been calling that out. But I think we need to, the first thing is being aware that more than one science exists. The second is understanding that the people who study those sciences actually have a specialism which is separate from medicine. So if you're a medic or a nurse or any clinician of any sort, then you need to decide how deeply you need to go into these. But I think also you need to respect that they are proper sciences in their own right, and there is a body of evidence that beneath it. So it is quite frustrating when you see people saying that they're doing quality improvement and it's a PDSA. It's one, they plan something, they do it, they study it, and then they move on, because that actually isn't PDSA. So, but it is, there are publications out there that say it is. So there's many that don't, but there are people who've published with that in there. So, and human factors and ergonomics, at the moment, there are some people with human factors backgrounds working in healthcare, but many people have come into healthcare and have run a mile because they find it so scary. You know, these are people who've worked in the nuclear industry, they've worked in shipping, they've worked in railways, and actually when they come into healthcare, they find so many things about the way we work just unbelievable and scary. And so it's really difficult for them to know where they can start, where they can make an impact. We do have clinicians who are studying human factors and ergonomics now, and that's great. They can bring the science to bear. But as with improvement science, you need people who actually are willing to call out that, you know, maybe you're not doing quite what you think you are, and your measurement isn't really telling you what it needs to tell you. But these are messages that are not always welcome. There is a new curriculum that's going to come out from HEE, which I should mention, which is patient safety, quality improvement, and human factors and ergonomics. And the idea is it's threaded throughout the curriculum, but it will take many years to come through in a really significant way. It's great that it's being started upon. So I think there's never a wrong time to start these things, but I think finding your entry point into quite complicated sciences is, you know, you're all bright people, but you have very little time. So finding a way in a way that you can understand and use these things is, you know, most people can think maybe about how they could use the Swiss cheese model. Very few people actually use it, but they can understand that. I hope that the SEEPS model becomes something which people not only can think about and understand how it's used, but maybe see which part in that model that they use when they're working on something. So if I just go back to that model here, if you're talking about briefings and huddles, whereabouts in the person in this blue blob, can people see me moving my cursor?
Yeah.
Do you see the cursor moving? Yeah, that's great. So how does that interact with, you know, what's your organization say about huddles? What does the external system say about it? So, you know, or pews, let's use pews, you know, what does the external system say? Well, CQC says you've got to be using pews charts, the national pews charts. Okay, so how does that work with individuals? Well, they use it because they've got it on their IT system, which makes them use it. And so therefore they perform their task very reliably. But then when it comes to escalation, that relies on them, whether they're tired, whether they have a system, whether the culture of the organization is a listening culture, whether it's a respectful culture, whether it's a speaking up culture. So, you know, you can begin to explore how small things work within this model and what are the questions you might ask about it. So that's really important. Yeah, so I think it's a journey, all of these things. Too much to learn in a lifetime.
Thank you. That's really useful to see how that model, you know, is applied to something like a very real life situation. Yeah. So thank you for that.
Okay.
And if anyone has an interest in quality improvement and maybe has a little bit of time to spare, do you have any courses or resources that you would recommend?
Yeah, so first of all, I'd encourage people to not just think about a pledge, but think about moving what they say they're going to do into action and picking something that's really tiny. So my advice to people is always pick something really small that you can actually have a go with. I have a lot of people who come with good quality improvement projects or exciting quality improvement projects, which are kind of save world hunger projects. Really start small. That is the learning point. We have this program, which is ST3s to ST8s, but we do have some ST1s and 2s that come on it. There are a whole set of programs through IHI which you can access for free. They are quite detailed ones. There are some quick resources you can get through other platforms around. And in fact, there's somebody's just put a tweet out, which I'll see if I can retweet, which has got a list of resources. As QIC Learn, we run blended learning and now virtual learning, all on social learning media, but these are programs that we do. There are individual programs available, but which you can find on our website if you're interested in, along with all the other people that provide great stuff. And I do know in London, for example, UCL Partners used to run a half-day training, I think, that was free as a sort of starter piece. I don't know if anybody is on the chat can say whether that's still being run. I guess they'll be making it virtual now. You find parts of organisations do really good pieces around quality improvement. And there's some learning resources on the CHFG website. So that's more about this. We've got a whole load of videos, 30-second to 1-minute videos, which kind of give you a bit of a insight into some of the sort of behaviours which we think are relevant to human factors. And in the resources that I've given you, I think I've put a few websites in there as well. So I've given you an introduction to quality improvement. That's the one at the bottom. I've given you a video about quality improvement, the links to the React series, and I did a little film of a 1-minute film of the improvement sciences, and then the link to the SEEPS model. So they're all on there for you, should you wish to get them. I think they've been sent in advance, so
yeah, they're on the learning pack for anyone who wants to access them.
Yeah, so I hope that's helpful. And if they want to see a really great poster about quality improvement, I haven't put the web address up here, but if you Google quality improvement clinic, then posters, then you should be able to see a whole load of posters of great QI work done by paediatricians and other people as well.
Yeah, great. Thank you so much for your time, Nikki. Thank you for introducing it and doing it so well. We really are so grateful for your time.
That's okay. I hope you enjoy the rest of the week. I hope everybody enjoys all the other talks that are lined up. It'd be great. Okay.
Thank you. Take care. Thanks. Bye-bye.